right. So welcome again, everyone. We are recording this presentation, and you can find this on our YouTube channel that is on this QR code. If you have your phone handy, then we do have a number of QR codes that will be showing in these intro slides that you are welcome to scan to get to some different links. My name is Kara Kaikini. I use pronouns she, her, hers, and I'm the Executive Director of the Maine State Breastfeeding Coalition. And before we start the webinar, I wanted to make a few announcements. So happy World Breastfeeding Week. Many of you know that this is World Breastfeeding Week, August 1st to 7th. It is also National Breastfeeding Month. And the theme for World Breastfeeding Week this year is making a difference for working parents. And in recognition of that theme, we are excited to give you all a sneak peek of 2 documents that we've been working on with Let's Go, a program of Maine Health's community health program. So we have started creating 10 or 11 different documents that will be part of a toolkit. And you can download these 2 that are ready so far, creating a plan to return to work and a sample return to work plan that is like a sample letter you can send to an employer. You can download that using that QR code or going to our website. I'll be sending a newsletter out later today that will have links for you to click on to download these as well. So we're really excited for, I'm not sure if Ashley has made it on yet. I think she was running late, but Ashley Edmondson from Let's Go has been a huge leader in getting us to this point. And so thank you to Ashley and other folks at Let's Go for being part of that process. And we're really excited about it. And when they're all final, we'll have one complete toolkit that can be downloaded. You can also download separate pieces too. So stay tuned. And if you sign up for this webinar, we will be adding you to our mailing list. If you don't want to be added to our mailing list, please send a message either through the chat or by sending an email to mainebreastfeeds@gmail.com, and we'll be sure not to add you. You can also unsubscribe yourself as well. Next up in our educational webinar series is a webinar on October 5th about donor breast milk in Maine. Kylia, some of you may have met her. She's the Director of Hospital Relations and Community Education at the Mother's Milk Bank Northeast. She's going to be giving an update on Medicaid and private insurance reimbursement for donor milk. I don't know if you all heard, we haven't fully announced this yet ourselves, but a law passed this session for private insurance to reimburse private insurance coverage of donor milk. And the system for Medicaid is still being built out, Medicaid reimbursement, and the same will need to happen for private reimbursement. Once we know a lot more about that, we'll definitely be sharing more info. And she'll just be giving an overall update on the latest in donating and receiving donor milk in Maine as well. So we'll be sending out sign-up info once we have that ready to go, and you can sign up for that then. And I also want to mention that recognition weeks and months like the World Breastfeeding Week and National Breastfeeding Month help raise awareness about breastfeeding and the need for more support. They recognize the families and the people and organizations like you who support them. And if you've ever considered giving back, there's no better time than during National Breastfeeding Month. So there are a few different ways that you can help sustain organizations like ours, the Maine State Breastfeeding Coalition, and the work we do to help support families. One is through donating your time. So if you have some time and you're interested in joining one of our committees, you can learn about them through that QR code. Also, this information is in our newsletter, and you can sign up to volunteer. That is always appreciated. And I'm going to, if you don't have your phone ready to scan these QR codes, I'm going to move kind of quickly through and just know that you'll get these in our newsletter as well. Another way to volunteer is to serve on our board of directors. So we are looking this month for applicants, for people to express their interest in joining, and we will be in touch about expectations and the process that we'll be going through in order to select board members. But if you have or know someone who has experience in nonprofit development, resource development, grant writing, fundraising, communications, any of that, let us know and we'd love to connect. And finally, another way to give is through donations of money. So we are a small nonprofit who operates on the generosity of sponsors like these and individual donations and grants as well once those start to come in. So our we want to recognize our annual patron partners so far: Acceleron, Soft Corner Midwifery, Dirigo Pediatric Dentistry, and Brandy Rogers. And our August supporter is Root to Rise, so thank you. We also want to thank Pump Spotting for matching up to $250 in donations this month. So any donations that come in this month, they will match up to $250, which is a huge add. So thank you so much for that. We appreciate any donations. As we like to say, every drop counts. So please consider making a donation through Venmo or through PayPal through that link there. And another thing that we are offering is with a donation of $10, can get access to view the recording of our Patchwork of Parenthood event that happened in May. So take advantage of that. It's really exciting. It's such a great event. Many of you were either there or heard about it and wanted to be there. So this is one way you can view it. And finally, to introduce our webinar presenters today, I first want to let you know that that QR code there is going to be a link to the evaluation for the webinar. So we like to get feedback. So once the webinar is complete, if you have that link all ready to go, that would be great to fill that out. And otherwise, we'll be sending an email to ask for your feedback. Thank you, Dr. Fritz and Virginia, Ginny, for being here today. Dr. Julia Fritz is a pediatric gastroenterologist at Maine Medical Partners and the Barbara Bush Children's Hospital. She graduated from Mount Sinai School of Medicine in 2011 before completing her pediatric residency at Maine Medical Center. She then moved to Milwaukee, Wisconsin to complete her fellowship training in GI at Children's Hospital of Wisconsin before returning to Maine Med in 2017. She's a clinical assistant professor of pediatrics at Tufts University School of Medicine and the rotation director and inpatient service director for pediatric gastroenterology at Barbara Bush Children's Hospital. In addition to her clinical work and role in medical education, she is active in advocacy, serving on the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition Committee of Public Affairs and Advocacy. Welcome, Dr. Fritz. I will also introduce Ginny, who is here and will be speaking, I'm guessing around halfway through. Virginia Weil holds a Master's of Education in Communication Sciences and Disorders from the University of Virginia. She's a speech-language pathologist and clinical specialist with 13 years of experience in pediatrics, and she primarily works at Maine Medical Center and per diem at Maine Healthcare at Home, Cumberland, and the Maine Chatterbox. This is the first I've heard of the Maine Chatterbox. I really want to look more into that. It sounds like a neat organization. She specializes in neonatal and pediatric feeding and swallowing disorders, the aerodigestive and cardiac population, and conducts, I just lost my place, I'm sorry, and conducts neonatal and pediatric swallow studies. So thank you both for being here. Dr. Fritz, take it away.
Thank you so much. I'm going to try to share my screen now. Can you see my slides? Looks like.
Yes, you are good.
Great. So thank you so much for being here, and thanks for that nice introduction. I was really excited to have the invitation to discuss this, which is one of my favorite topics of feeding infants. And so we're going to be talking through some of the challenges that we see most commonly. And I think that we have plenty of time through at the end of the discussion for questions, but certainly feel free to add them to the chat as we go, or especially because this is a audience with a mix of backgrounds. If I'm not making sense, you can certainly unmute and ask me in the middle of the presentation if something needs clarification. So we have no disclosures. I will, however, disclose that I learned last night that it's World Breastfeeding Week, but I guess better late than never. So happy World Breastfeeding Week to everybody. Our objectives today are to discuss how to troubleshoot some of the feeding challenges that we see in the first 6 months of life. And as I said, we'll have plenty of time at the end for questions. I'm going to be talking about reflux and when to worry more. I'm also going to spend a fair amount of time discussing different intolerances and the question of elimination diets. as well as talking a little about poor weight gain before Ginny jumps into some of the difficulty that she sees with breast and bottle feeding and how to navigate that. And then we have some resources at the end that may be helpful in sort of rounding out the education. Before we jump in, I wanted to sort of set the stage with a case or a patient that is someone that we would encounter quite frequently, and I'm sure in various ways you've encountered similar patients. So this is a newborn female who was born at 37 weeks and came to the attention of us because of some arching and gagging whenever she was put to the breast. And she would also, whenever she was offered a bottle, tongue thrust and not be interested. In the history, her mother has celiac disease, and she has an older sibling who was reported to have lactose intolerance. And then she was noted to have some slow weight gain at her early well child check, and the pediatrician started her on omeprazole. Mom started eliminating milk from her diet, and the pediatrician also said we need to start bottle feeding formula for supplementing. And so I think this is sort of a representative case that illustrates some of the topics that we're going to try to discuss today, and some of the ways that we might think about these different problems. So the first problem, which is probably the most common, is reflux. And I say that it's the most common problem because it's really something that we deal with every day. And that's quite literal, because not only do I see in my practice patients with complaints of reflux, but it's a natural phenomenon that is happening to all of us throughout the day, whether or not we recognize it. So reflux is caused by these transient relaxations of the lower esophageal sphincter, which happens throughout the day, and when the stomach is full, that allows for some stomach contents to enter into the esophagus. And so there's a number of different factors that contribute to how high the reflux may go, which includes the content of the stomach, it includes gravity, and also the length of the esophagus, and therefore the location of the lower esophageal sphincter. And so this is a schematic put out by our National Society for Pediatric GI that illustrates why infants may be more prone to have at least visible reflux. And they have the shorter esophagus, they have smaller capacity in their stomach, their gravity is working against them. And so it's definitely, they're a setup for very apparent reflux. But what's important is that, although reflux happens, there's a distinction between physiologic reflux, which happens at all ages, and is an important physiologic mechanism to allow for the stomach to depressurize, and that it should be separated from gastroesophageal reflux disease, or GERD, which is pathologic. The definition of GERD is that there's reflux and it's causing troublesome symptoms or complications. And so you can think that in infants that becomes tricky because, well, you or I could say, oh, this is causing heartburn, this is uncomfortable. Infants, we're relying on interpreting their signs of reflux, and that may vary based on the parent and how bothered they are by seeing some spit up, and it may vary on the infant and how sensitive they are to, or how they respond to the physiologic reflux. And so it's also important that some signs that are often attributed to reflux may not be truly reflux related. So oftentimes irritability and some difficulty with feeding is attributed by parents to being related to reflux, but may not actually correlate. So there's a study that was looking at this pH impedance monitor, which is basically a tube in the that goes into the infant, and along the tube it has pressure sensors and sensors for whether there's liquid or gas, as well as what the acidity level of that liquid or gas is. And the tube goes from the nose into the stomach and is really the best way to measure whether reflux is happening. And so in this one study looking at preterm infants, they were seeing that reflux was incredibly common. So it was happening 71 times in the course of a 24-hour period. But interestingly, the things that the nurses or families were noting as signs of reflux being that they were irritable or they were looking uncomfortable was rarely associated with an actual reflux event. And so it sort of brings into question, what are we interpreting as pathologic? And so when we're teasing out what's sort of physiologic reflux versus the reflux disease, we then think about, if we have determined that these symptoms are troublesome enough to be considered GERD, what are we going to do? And so these are guidelines that are put out by our national society, and I'll sort of walk through them. That we really start by looking for any red flag symptoms or alarm signs. So that includes weight loss, fever that would suggest a systemic infection, late onset or persistent symptoms would, so after 6 months or persisting after a year, may make us think about another reason for the reflux, not outside of GERD. And then if we're seeing really persistent forceful vomiting or especially bilious vomiting, we would be more worried about sort of an anatomic problem and think about a more urgent evaluation. And so once we determine if there are any alarm symptoms, the next step is to think about some of the non-pharmacologic interventions for reflux. And so the first on the list is the avoiding overfeeding. And I really don't want to underemphasize this, because that can be a huge piece of what we're seeing, where if babies are filling their stomachs to the very brim, as soon as they're put on their back, they're going to have gravity work against them, and you're going to see some of that come back up. This also mentions the potential for thickening feeds. And although there's no studies on whether thickening feeds truly affect reflux symptoms, it is something that can cut down on visible regurgitation, which, I question how much that's actually an important piece. Like, if they're not that uncomfortable at what you're seeing, the reflux, is that really a problem? And there's also some significant downsides in thinking about thickening feeds, especially in breastfeeding infants. And then the last step in this guideline before thinking about referral to GI is to consider eliminating cow's milk protein from the infant's diet, either by an elimination diet in mom or switching to a specialized formula. And I'm going to go into this in a lot more detail in the next section, but I want to make a note that even in the absence of some of what we think of as classic signs of cow's milk protein intolerance, being the blood in the stool, it's sometimes a change in the diet can be helpful in decreasing the amount of reflux symptoms. And then I also want to highlight from this guideline that it's only after all of these steps that we would even think about using an acid suppressant. And the reason for that is that because there's really good data on the potential risks of these medications, including increasing risk for respiratory infections. And there's very, very limited data to support their use, because the problem with infants and reflux is rarely the acidity, which is the only thing that the acid suppressing medicines do. Is they can't help with the length of the esophagus, they can't help with the gravity, and they can't help with the amount of food that's in the stomach. So it's really only in patients who are continuing to do poorly after we've tried these other interventions that we would even think about using an acid suppressing medicine. And so just, from my perspective as a GI physician, so we do get these referrals a lot. And this is on the right, our referral guideline that we've come up with, which basically is in line with the guidelines that our National Society came up with. But when patients who are concerned about reflux in their infants come to see us, we do review the history and make sure that there's no reason to think of something more serious going on, anatomic problems. We talk to them a while about their feeding strategies to see if there's any interventions that we can do there. We think about whether imaging is necessary. And then we spend a fair amount of time talking about the pros and cons of an elimination diet or a change in what the infant is getting. And then we also generally will talk about why or why not would we use any medication. So a PPI or acid suppressing medicine, as I said, comes with some risks. And then we also will sometimes think about the use of a prokinetic medication, which is something that helps the stomach empty and so moves the food along faster, so that hopefully you're seeing less of it come back up. But even those medicines come with some pretty significant risks, and we like to avoid if we can. Oops. So I'm moving into the second sort of big problem that we see, and I alluded a little bit to the possibility of milk protein allergy. So that's going to be what we talk about now. This is a schematic on the left showing the makeup of milk, and obviously it's largely water, but within the different macro and micronutrients, we have lactose that makes up a good portion of the calories that infants get, as well as the fat, and then the milk proteins only seem to make up about 1% of breast milk. And so when we're talking about intolerances, it's very, very common that people will jump to lactose intolerance, and that is not accurate in infants. So what most people consider lactose intolerance is a loss of the lactase enzyme, which is used to break down lactose and occurs naturally in about 75% of the population, somewhere around 2 to 4 years of life. And so that's what true lactose intolerance is. And this lactase deficiency has been reported in like 16 infants. And so it's exceedingly rare. And infants are, because they rely on milk for all of their nutrition, they have great lactase activity, and it's only as they age that they start to lose that. That being said, some infants can have a secondary lactose intolerance, which is something where where after an illness, or if they have some inflammation of their gut that affects the enzyme activity, they lose some of their ability to digest lactose. And so you may see symptoms that are classic for lactose intolerance in an older child, in infants sort of after a GI bug or something like that, and that can last even months. You also can have variable responses to lactose based on your gut microbiome, which is another thing that we consider when infants seem to struggle with the lactose component of milk. So that's often something that we clarify with families who are coming with concerns for a milk protein intolerance, because when we're thinking about symptoms related to milk intake, we're actually thinking about the reactions that they have to the milk proteins. So generally that's the whey protein, because these are highly soluble and will easily pass through the gut epithelium and produce symptoms. There was just last month a new paper put out that is the European Society's guidelines around this cow's milk protein allergy. And they were seeing what they reviewed all the articles and research in the last 11 years since their last guideline, and concluded that it seems like cow's milk protein allergy is actually fairly overdiagnosed. And if you're looking at a sort of proven milk protein allergy, where the symptoms resolve with removal of the milk protein, come back with reintroduction of the milk protein, and are sort of reliably proven, it's only about 1% of the infants. But interestingly, when you look at the different symptoms that families are attributing to milk protein and relying just on that, it's about 10% of the patients who would be diagnosed based on family report. I also wanted to point out, because this is another thing that I like to make clear to families, is that the majority of this milk protein allergy, even though we call it an allergy, it is non-IgE mediated, which means that it's separate from the sort of more classic food allergies that we think of, like a peanut allergy, where you're at risk for anaphylaxis. If it's a non-IgE mediated allergy, we're not seeing those severe symptoms. And interestingly, it's a different, so it's the casein protein that's more at fault for the IgE mediated allergies. This is a table from actually an allergy paper that goes through the variety of non-IgE mediated responses that we see. And again, I think we do ourselves and our patients a disservice by classifying many of these under the broad category of a cow's milk protein allergy, because there really is some distinction that I'll go into a bit later, that some of them may not even be a true problem. But we hear about FPIEs, where there's either acute FPIEs, which is really forceful vomiting soon after ingestion, and chronic FPIEs, which may be longer, intermittent, but can have some additional symptoms, including poor growth. There's food protein-induced allergic proctocolitis, I think is what most people think of with cow's milk protein allergy, whereas there's blood in the stool, and you may have some other changes in the stool as well, including mucus. There's EOE, or eosinophilic esophagitis, which is not a disorder in infants, but is something that I see often. And then I'm going to get back to the food protein-induced constipation and the food protein-induced GERD later, because I question whether that should be included in this table. And then the food protein-induced enteropathy is where we're seeing poor growth and diarrhea just based on the inability for the gut to absorb the nutrients. And so I wanted to sort of go through the different symptoms that we see that might be attributed to milk protein allergy, but also bring your attention to the different food triggers. So we do see that cow's milk is the most common trigger for these, whether it's in the infant's diet or mom's diet. Soy is sort of the second most common, but then especially with FPIEs, you can have it with other foods. And so it's gets into some muddy water as we think about what we're going to be eliminating. As I mentioned before, the diagnosis of a true non-IgE mediated cow's milk protein allergy requires an improvement of the symptoms following removal and then a recurrence with reintroduction. So I think it's hard to say once somebody's improved, let's go back and make sure that we really have proven this. But it's hard to say if you see improvement with removal but never reintroduce it, whether it's truly cow's milk protein allergy or something else potentially developmentally that we're dealing with. And it can present with just reflux and irritability alone, although often there's associated eczema or some other sign of an allergic response. The symptoms are typically presenting within the first 3 months of life, but it can come anytime in the first year. And I really wanted to highlight, if there's one thing you take away from this, is that the need for treatment is really only dependent on symptom severity. And I'll get into that a little bit more, but the tolerance to the triggering protein is usually achieved by 1 year. So patients do outgrow this. And then there's some difference in opinions in terms of the FPIs should be have sort of skin prick testing before they before foods are reintroduced, whereas the other symptoms we feel safe reintroducing without that more significant testing. And so this is a quote from that recent European guideline that I wanted to bring attention to, which says the food protein-induced allergic proctocolitis occurs mostly in breastfed infants, and that's just the blood in the stool without other associated symptoms, and is most cases a benign, easily recognized condition that may not need treatment in some breastfed infants, depending on the severity and frequency of blood in the stools. And I think that that is true with all of the different symptoms that we see that we can attribute to non-IgE mediated milk protein allergy, is that if the baby is otherwise doing well, the need for eliminating foods is not necessarily there. It may be helpful in the diagnosis, but it doesn't put them at risk for, if we're not treating it, it doesn't put them at risk for problems down the line. And really, especially thinking about breastfeeding and eliminating foods from mom's diet, we worry that it may do more harm than good, because we're then putting mom's nutrition at risk, and also putting the breastfeeding experience at risk. If we're going to treat, we think about eliminating foods from mom's diet, and the timing of sort of how long you need to eliminate before you're going to achieve full elimination depends on factors that we can't necessarily measure. So mother's own intestinal permeability, some of the breastfeeding factors like how empty do you get with each feeding, and then mother's intake of the offending protein. And so we usually quote sort of 2 weeks. We know that it's usually out of the breast milk between 3 and 5 days, but before seeing complete resolution of the symptoms, we quote families 2 weeks. But I always say you can feed through that if you want to, because as long as the baby is growing, then you might continue to see blood, but it's not going to be hurting them. And then if we are thinking about patients who really need to recover quickly, which is really those who are not gaining weight well because of this, we would think about using a formula. Hydrolyzed formulas break down the proteins so they are better tolerated, and with a simple hydrolyzed formula, you can have 90% of patients that would improve. And if they don't, then we think about using an amino acid based formula if they haven't resolved on the hydrolyzed formula, or if we don't have the 2 weeks to wait because they're having such poor growth. I do think it's important with all of the, again, thinking about treatment versus not, that quality of life considerations are important, and there's also a significant healthcare cost associated with these different formulas. So I want to go back to this chart, because from a gastroenterologist perspective, some of these reactions actually fit into some other diagnoses. So the food protein induced constipation, which is straining with soft stools, is something that we see commonly and is a normal developmental stage. And we call it infant dyschezia. And it's just that the infants are learning how to coordinate their pelvic floor muscles to pass the stool, and that sometimes that looks uncomfortable. But it doesn't come with any other significant problems. And then in addition, they put in the food protein induced GERD, and that goes back to the question of whether this is truly a troublesome symptom versus just normal baby regurgitation or physiologic reflux. And so those, I would argue, even stronger against making significant changes in the child's diet. So again, if they cross my path, I try to provide as much education as possible. I try to reassure families, and I have an in-depth discussion about the pros and cons of an elimination diet, both for mom and the baby. So I talked about both refluxes and intolerances, and that as a pediatrician, I try not to intervene in these for fear of doing more harm than good. And that all changes when poor weight gain is in the picture. So it's not uncommon for families to come to us and not be concerned about the weight, but be concerned about something else. And then when we're looking at the growth chart, we think that we need to make some significant changes immediately. And the reason for that is because nutrition is so important to so many outcomes, not just developmentally, but also it's key to outgrowing your reflux, and it's key to outgrowing your intolerance if you really need to have the infant growing and maturing. So poor weight gain is sort of in a field all by itself. And when I think about poor weight gain, I really divide it into three categories. So the metabolic demand, which is how many calories do you need to live? And that can be impacted if you have congenital heart disease, if you have significant respiratory effort, if there's an underlying infection, and then less commonly in infants, but hyperthyroidism and malignancy are also things that would increase the number of calories that you need just on a day-to-day basis. The next category is sort of too much out or malabsorption and losses. Again, with infection, you can have significant diarrhea that leads to inability to absorb all the nutrients. I talked a little about that secondary lactose intolerance following an infection. And then the non-IG mediated food protein intolerances if you have the enteropathy. Cystic fibrosis can lead to malabsorption, and then very significant vomiting can also lead to such significant losses that babies struggle to gain weight. And then the third category is not enough in. And so this is usually a question of low volume versus low total calories, which may be impacted by sucking or swallowing dysfunction, and then less common in infants, but sometimes present is a low appetite. And so when we think about these three categories, metabolic demands, we're pretty good at discerning from a physical exam. The malabsorption and losses are usually we're able to get to from the history. And then it usually will put us into that third category. We're trying to figure out what exactly is causing them to not get enough in. And that can be a struggle. And that's where we generally enlist the help of our speech language pathologists. So I'm going to turn it over to Ginny to start talking about the difficulties with breast and bottle feeding.
Hi, everybody. Can you hear me, Dr. Fritz?
Yes.
Great. Oh, can you advance the slides though?
Yes.
Thanks. All right. So usually the kiddos that I see, the big question is there a tongue tethering? Another one would be airway compromise concerns. So if we're concerned about aspiration at breast or the bottle, And then if we are having some airway compromise events, changing the viscosity of the liquid, so thickening. Next slide. So tongue tethering, very controversial in the speech pathology lactation world. Very controversial, lack of high quality evidence to support releasing unless for breastfeeding for babies less than 3 months of age. There, of course, is controversy. You know, the otolaryngologist here feels, oh, there's no difference between an anterior versus posterior. But if I ask 50 of them, I'm sure I get 50 different answers. The impact on breastfeeding. So a tongue tethering, you know, does it impact the ability for the baby to actually transfer the milk? So a lot of times I'll see moms who feel as though the baby is, you know, latched on and sucking for 10 to 15 minutes, great oral transfer. And then Elsie or myself will do pre and post weight. And unfortunately, the baby's barely transferred anything. So we think about that in relation to a tongue tethering. Also, a deep latch on the breast. So we will look further into the tongue tethering intervention if moms and LCs feel as though the baby can't get a deep latch and can't extract well. Tongue tethering and the impact on bottle feeding definitely can impact the latching efficiency. But usually we can get around it by finding different shaped nipples, different flow of nipples. And the other piece of things that is a little controversial as well is the swallowing of air and gassiness. I feel like more personally, anecdotally, I've had families after an intervention of a tongue tethering say there's decreased colicky behavior, which in my mind as a speech pathologist, I do think of how the tongue moves and the base of tongue, and if a tongue is tethered, it has to impact the full movement of the base of tongue, which can then have this snapback movement, which then creates an air bubble, which then, you know, leads to aerophagia and just discomfort for the baby. So if I see a baby that there's any question of a tongue tethering, I usually talk to the family about a referral to a pediatric dentist on an outpatient basis, or referral to a pediatric otolaryngologist. I feel as though, you know, I've been to a lot of conferences and listened to speech pathologists and otolaryngologists from across the nation. And I feel like every state is a little different in whether they swing the pendulum towards a clipping in the ENT office versus the pendulum towards the pediatric dentist, and we get a good CO2 laser. So here in Maine, I feel like it's definitely more towards the dentist. And so we have some references at the end of the slide, at the end of the presentation for some PD dentists in Maine that we refer to or mention to the family. And I will say some of our otolaryngologists do come up to the newborn nursery here at the hospital. If LC and moms are really complaining of nipple pain, bleeding, poor latch, impacting breastfeeding, they do come in and they do clippings, but I will say it's more of the dentist here in Maine. So airway compromise. So babies can have signs and symptoms of penetration or aspiration at breast or with bottle. Same symptoms: coughing, increased congestion, a wet vocal quality. So if they cry or if they bring their cords together at all and make any sound, you kind of hear this wetness or this gurgliness on the vocal cords. Can be a symptom of aspiration or penetration. Babies with recurrent respiratory infections, cyanotic events with oral feeds. Sometimes that could be from reflux when they're trying to figure out how to breathe after they close their vocal cords to protect their airway from reflux events. And then more and more what the otolaryngologists and I are finding is increased stridor, which is that inspiratory squeaking sound. But families report they only hear it with feeds versus throughout the day during non-feeding times, because what we're finding is that babies are trying to protect their airway a little bit more. And so we hear the result would be inspiratory stridor. And so a lot of times, like today, I just saw a baby upstairs. When he started really gulping at breast, immediately started with that inspiratory stridor. So is it the increased respiratory effort, or is it that he's aspirating a little bit or penetrating a little bit? His cords are kind of closing to help protect the airway. I'm not sure. So how do we assess the swallow function for infants that we feel may have airway compromise events? So we can do the modified barium swallow study, which is the image on the left, includes fluoroscopy, or we can do a flexible endoscopic evaluation of swallowing. And here we do it in conjunction with ENT, and that's kind of the image that you see on the right. So MBSs are more lateral. The babies have to take a bottle with barium in it to get a good valid study. So a lot of times our primarily breastfed babies, we don't get as much of a good valid study when they come in and they have a bottle for the first time. Different flow compared to what mom's flow is. It's a foreign nipple compared to what they're used to. So if I see a baby and parents and medical team are concerned about aspiration events, I will really suggest doing a FEES with ENT so we can latch the baby to mom and really see them functionally, how they're able to protect their airway. And it's also a nice way to assess for laryngomalacia or any kind of other upper airway anomalies at the same time. So for here in Maine, who to refer to, I would say refer down here to Maine Medical Center to do the infant swallow studies. Like I said, must take a bottle. And then for a FEES with ENT, we have some great pediatric otolaryngologists. So I say refer to Aerodigestive Clinic. And that would be for exclusively breastfeeding infants, or if you see an infant in the home or in your office, and you have concern for their management of secretions, because they're just always sounding junky, or you fear, you know, they may appear to have some kind of tone, decreased tone. A FEES would be another way to assess swallow and management of secretions. And again, we would refer to Aerodigestive Clinic here at Maine Med or through Maine Medical Partners. So our Aerodigestive Clinic is pretty comprehensive. We have 2 pediatric otolaryngologists. We have 2 pediatric pulmonologists. We have the amazing Dr. Fritz. We have 1 cardiothoracic surgeon, Dr. Malhotra, myself, and then, you know, common diagnoses, the chronic airway disorders, airway anomalies, feeding issues, aspiration, reflux or aspiration of reflux concerns, and then the neurological disorders and syndromes that could affect breathing and swallowing, like our malasias or traits and vents or CP. So what happens if you have a patient that needs to be thickened? So we have a few different options. So I'm sure you guys are aware of gel mix. It is a commercially available thickener that is you can use with breast milk, which I believe is the only one out there for kiddos under 12 months of age. The only caveat is they have to be greater than or equal to 42 weeks PMA, so 2 weeks corrected, and they have to be 6 pounds. Many times if they have any cardiac diagnosis, I do get clearance from cardiology for any thickening, just to make sure that we are not setting them up for some kind of issue down the road. One of the side effects with gel mix is that there is a report of increased gassiness and loose stools for about 14 days, but then the gut kind of settles out. It is hypoallergenic in the sense of it's vegan, gluten-free, dairy-free, soy-free. So it's great to use for moms who are eliminating and, you know, the GI has diagnosed with some kind of intolerance or allergy. Then we have our thickened formula. Typically here we'll use Enfamil AR. We will not use Similac for spit up because it's not thicker in the bottle. It thickens in the stomach with the stomach acid. So for aspirators, we definitely use the AR. And for solo refluxers, we'll try to use the SIP for spit up. And then cereal. So typically, because the cost is a lot less, we'll recommend cereal if babies are just on formula. It is sometimes a hassle to try to find a nipple and a recipe that works well, that it's thick enough, you know, to help with the aspiration and or the reflux, but we need to find a nipple that's big enough, but not too big that the cereal flakes can come through. So what we found through trial and error is the Dr. Brown's level 3 and 4 or the MAM level 3 are the nipples we found that cereal can come out of. We discourage the cross cut and the Y cut because it's just too big when the babies actually latch and extract and they can get flooded. Basically what I tell the families, certainly if they're on like the Avent bottles or the Duna or Lancina or whatever, the reason why we recommend MAM and Dr. Brown's is the hole of the nipple. As you increase flow rates, one hole gets bigger, versus a lot of brands will just increase the number of tiny holes, which doesn't help the cereal flakes to come out. And then some emerging research is showing that typically we need to thicken 1.5 teaspoons to 2 teaspoons per ounce of formula to actually make a difference with reflux, and it also bounces the viscosity up to as like a slightly thick consistency for aspiration. The other thing that we're starting to do here is if babies are needing on breast milk and we've done a swallow study on them, they're not aspirating on thin liquids, they have a good swallow function with thins, we are starting to thicken breast milk with cereal if it's more for reflux or the oral sensory need to be thickened. But as long as we've ruled out aspiration on thins, because we don't want the breast milk that's thickened to be broken down to a thin liquid and then they aspirate. So it's definitely like a case-by-case discussion on whether we actually use cereal with the breast milk.
Great. So just in summary or conclusions, so we talked a little about GERD and the difference between sort of the physiologic reflux versus the reflux disease, and really that for most patients and most babies, workup and treatment are unnecessary. We also talked about some different intolerances and how to distinguish. And for cow's milk protein allergy, the diagnosis really is the treatment, or is in the treatment. And with these, the really important piece is to have a good discussion with the family, teach about the difference and what they might see, and provide reassurance as long as the baby is growing. And then when the baby is not growing, deciding whether it's because they're not getting enough in, which is most common, and what the reason might be for that, versus too much out or using up the calories that they're getting. And when we're thinking about whether they're not getting enough in, really looking to see if there's difficulty with the breast or bottle feeding that might be contributing, whether it be tongue tethering or aspiration concerns. And so with that, we have some last resources, and I am going to try to stop sharing so that we can have some discussion.
Excellent. Thank you so much, Dr. Fritz and Ginny. That was really fantastic, really informative. Now is our time for some questions. I know we had some come through, so I'm going to go back to those, but if you have a question, please type that in the chat box and we'll be sure to get to that. The first one you may have seen from Robin, I wonder about introducing something else with breast milk for thickening before 6 months. What about the maturing gut membrane? It's still permeable in the early weeks and months. How would you answer that?
Do you want to take that, Ginny, or do you want me to? So I think that if we're thickening just for reflux, and that's sort of safe reflux. So if we're thickening because we don't like seeing kids spitting up, I would encourage families not to. If the baby's otherwise doing fine and they're not seeming super uncomfortable and there's not concern that they're aspirating on their reflux, then I generally try to reassure them that they will grow out of this phase. If there is concern about aspiration or other issues that we are thickening for, then I think that the benefit outweighs the risk even before 6 months.
Thank you. See here, and Evan has the question, has anyone used an SNS, a supplemental nursing system, for the barium test?
We have not. I will say here at the hospital, we don't use them that often. And if we do, it's like for a very specific case, we work closely with LC. I don't think I've ever had a mom come in though with an SNS feeder to say, hey, I want to try this, let's put the barium in here. And I just don't know if the radiologist would want to radiate breast tissue, because we would still have to have the baby latched on with it hooked up. That's a very creative idea. I would actually have to ask my radiologist. I'm going down there soon, so I can ask and see, but I doubt they would radiate just for that.
That's a great question.
Tissue.
Thanks for asking that. Yeah, and looking into that further, Jenny. That would be a good thing to ask about in case that comes up as an option. And then it looks like we have questions about showing the contact information again, either putting that in the chat box or showing that slide again. And are you interested in sharing your slides? That's something, if you are interested in sharing those out, Dr. Fritz and Ginny, then email them to me and I can put them out to either just those who attended or whatever you feel most comfortable with.
We're happy to, we need to make some modifications, but we're happy to send those out.
Okay, excellent. Any other questions? Yeah,
I think I have one more thing. I have one more thing to add. I forgot. This is my big thing, and I forgot to say it. In terms of tongue tethering, we look at function. I mean, we have a lot of babies, and I'm sure a lot of you have experienced this, where babies have some severity of tongue tethering or lip, and they can still functionally and safely breastfeed and or bottle feed. And I think sometimes that pendulum can swing of, oh my gosh, everybody has to have intervention for their tongue tethering, to, oh, everyone is fine. And I think it's hard to find that happy medium. And I feel like, you know, some of the parents that we talk to, they hold on to, oh my God, my kid has a tongue tie. I need to get it clipped. I need to get it clipped. And how do you find that balance on explanation and talking to the whole team saying, let's talk about this together. And let's really look at the safety, the function, moms wanting to breast or chest feed, and really looking at that piece, because, you know, I've had, even some of my speech colleagues, their kiddos had huge, pretty moderate to severe tetherings, but they safely and efficiently breastfed without any maternal pain, and they bottle fed, they're eating and they're speaking well. So I think we don't always want to rely and jump to the tongue tethering being the reason for issues. Always, you know, talk to your team and really look at the function of it.
Yeah, thank you so much for pointing that out. I think that was really helpful to hear too from Dr. Fritz, that even with blood in the stools, that intervention isn't always necessary. There was someone who came to the Maine Med breastfeeding group on Tuesday with saying that they were completely taking out dairy as a result of that, which is something that I would have thought would be necessary too. Blood in the stool seems like something that would warrant intervention, but that's helpful to hear. And I wonder what pediatricians and family practice doctors are also looking at it in that way too. I know that you've provided education through the AAP, Maine AAP too.
Yeah, I think that it's I'm glad that there are new guidelines out that hopefully we can share more widely, because it's been our practice to at least offer support if they want to pursue an elimination diet, because I understand not wanting to see blood in every diaper. It's scary. But also, you know, supporting if they want to continue their diet, that there's no harm in baby, no harm for the baby. But it's been, I think, hard because we're coming with a problem and we want to fix it, and it generally does lead to improvement in the blood, but the discussion is really about, you know, whether the blood is a problem or not, or just sort of a natural response that they will outgrow.
Yeah, thank you. We have several questions that have come through, but we are at 1 o'clock. So I don't know if we can just take one more question. I will take the first one that I see from Rachel. Can you talk about offering formula versus breast milk and the relation to food allergies? I don't have the exact data or info, but I think I saw a study where babies that had formula or a mix of formula and breast milk were less likely to develop food allergies related to peanut or egg. So is there anything you can share about that?
So I also know that study, but I don't remember the exact data. There's evidence to support breastfeeding. It has lower risk for allergies of all sorts. So environmental allergies as well as food allergies, but the data is not strong enough, I think, to say more than that. And in terms of sort of a mixture, how that plays into it is hard to say, but we always encourage breastfeeding if we can for all the different multitudes of reasons, and but it's certainly not a one-for-one that formula fed babies are sure to develop some allergies.
Thank you. And then I don't know, let me just do a time check for you, Dr. Fritz and Ginny. And if folks have to go, you can go. This is being recorded, so people could come back and watch if you have a few more minutes to answer the questions.
I have about 3 more minutes, so.
Okay, well, we'll try. Let me just ask the tongue-tie questions here. I know Amy had her hand up earlier. Do you have recommendations to learn more about how to assess tongue tethering if it's an issue? It seems like it's so subjective. And then the next question, how common is it to correct a tongue tethering later in infancy? If a mom chooses to defer, but once solids are introduced, there are significant food movement issues within the mouth. Is it unreasonable to look at correcting the tethering at that point? Great questions, Ginny. How would you answer those?
Yeah, so I'll quickly answer because I do have to go. So I'm just referencing another presentation I went to. There is the Correlos Ankylosing grading scale, the Bristol tongue assessment tool, the Tabby tongue tie and breastfed babies assessment tool. And they focus on the physical characteristics of the frenulum in terms of how to grade it in terms of severity or 1, 2, 3, 4, but they don't address the functionality of the tongue. So we have to remember about that. Yes, I have had some kiddos get lasered later, like when they start purees and the parents realize that they're having a difficult time manipulating the bolus, or they start to do solids and they really see that tongue tip is not really lateralizing, it's more of that mid blade going side to side. They will go and get a assessment done. Again, usually here in Maine, they go to a pediatric dentist to do that. And then we have, on the rare occasion, we have had older kids when it's affecting speech, they will get it intervened or, get it assessed. But I feel like right now the highest incidence is the infants in terms of bottle and breastfeeding. Did I answer all the aspects?
I think so. Yeah, thank you. And I asked if anyone wants to share here what tools they might use. And it's helpful to hear from you as a speech and language pathologist. Ginny, you're seeing kids later who might have speech issues, because I think that's often a question early on when parents are deciding whether or not to have that tongue tethering revised. It might not be affecting feeding, but might it affect speech later? Let's take care of it now. Seems to be a very, very common response, but you're saying it might not always affect speech later.
I feel like if it's going to and I feel like if it's going to affect the speech later, it's likely affecting feeding somehow, because that means it's pretty severe in terms of the tongue tip to hit those T's, D's, L's, THs. You have to have that tongue tip elevation. So if you're not doing that, I'm guessing that's going to be impacting solid food efficiency.
Thank you both so much for giving this excellent information, sharing all of this with us. Thank you so, so much. And thank you everyone else for being here to listen and supporting this education and our organization as well. Have a wonderful rest of your day.
Thank you so much for having us.